right, well, I have 1 o'clock Eastern, so we will go ahead and get started. Thank you so much for joining our Superior Health Quality Alliance Roundtable conversation for today around the COVID-19 isolation and quarantine guidance. For those of you who I haven't met, my name is Kelsey Ostergren, and I am joined by my colleague, Kim Heft, and together we will be leading today's meeting. So as you may have seen in some of our recent Superior Health communications, we really want to be sure that our team is providing hands-on assistance related to COVID-19, to the vaccines and the boosters. So this is sort of a kickoff of a new weekly series of sessions that we will be hosting to highlight some of these important topics, and really just hope that, each week you'll be able to join us for a quick 30 minutes, maybe grab lunch or a drink, some more coffee, and just kind of hear some updates and ask any questions you might have as well. So these are our objectives for the call today, really with the changing guidance and the ambiguity around some of what applies to healthcare professionals, what applies to the general public. We just thought it would be nice to recap some of this information and try to provide as much clarity as we can on these topics. We also know that staffing has been an ongoing challenge for many of you, so just trying to give as much guidance and clarity that we possibly can so that when your staff can come back to work, which I have no doubt is something that you guys are all thinking about, focused on, and trying to make sure you're following the guidance and protocols while also maintaining staffing levels within your facility. We'll also spend a little bit of time talking about contingency and crisis standards and the role that plays as well in when staff can come back to work. So with that, I will turn the call over to Kim, and she is going to take us through some of the background on this information. So Kim?
Excellent. Thanks, Kelsey, and good afternoon, everyone. So let's go back to 12/27/21. Okay, that's when CDC updated its public and healthcare guidance on isolation and quarantine. Due to concerns about increased transmissibility of the Omicron variant, the guidance from CDC, it's being updated to enhance protection for the healthcare personnel, patients, and visitors, and to address concerns about potential impacts on the healthcare system given the surge of COVID. The change was motivated by science because it demonstrated that the majority of COVID transmission, it occurs early in the illness, generally in that first 1 to 2 days prior of symptoms, and then 2 to 3 days afterwards. So this, coupled with the huge workplace impact that Omicron is having, has resulted in this guidance revision. So these two terms, up to date and fully vaccinated, they're used frequently throughout CDC guidelines. Up to date means a person who has received all recommended COVID vaccines, including any boosters, when eligible. You're also considered up to date right after getting that booster dose. Now, fully vaccinated, it means a person has received their primary series of COVID vaccines. And currently, being fully vaccinated is the requirement for the vaccine mandate. By the way, that first step looks like it's due tomorrow, the 22nd, and then February the 28th is that second step. Just a little reminder there for you. Note there are circumstances for when that third dose is warranted and is considered part of being fully vaccinated. These third doses are for those who are moderate to severely immunocompromised. So we're just going to go over the general public quarantine guidelines first. This guidance applies to, again, that general population in the community. That includes, your typical workplaces and your K through 12 schools. This does not apply to healthcare settings. So for quarantine guidelines, if you are exposed to COVID and you are not up to date with vaccination, you should be quarantining for at least 5 days, get tested on day 5, and wear a well-fitted mask for the 10 days. But if you are exposed and you are up to date with your vaccination, or you had confirmed a COVID infection within the last 90, you do not need to quarantine, and you should be wearing a well-fitted mask for 10 days. So general public isolation guidelines, you want to isolate when you are sick or when you have COVID-19, even if you don't have symptoms. Isolate for 5 days and end isolation after 5 full days if you are fever-free for 24 hours. And of course, that's without the use of a fever-reducing medication, and continue to wear a well-fitted mask around others at home and in public for your 5 additional days. Just to note, to calculate your 5-day isolation period, day 0 is your first day of symptoms. Day 1 is the first full day after your symptoms developed. So again, you can leave isolation after 5 full days. So then we go back a few days, back in December, on the 23rd, the CDC released emergency guidance for healthcare facilities to prepare for the potential Omicron surge. It includes guidance for isolation and quarantine and for contingency and crisis management in the setting of significant healthcare worker shortages. And 2 key takeaways from the quarantine guidelines. One is that asymptomatic healthcare personnel who have had a higher risk exposure do not require work restriction. If they're up to date, remember up to date could be, if they're eligible for the booster, so they need that booster, with all recommended COVID vaccines, they do not develop symptoms and they do not test positive for COVID. The other takeaway would be that also asymptomatic healthcare personnel who have recovered from the COVID infection in the prior 90 days, they do not require work restriction following a high risk exposure. So, there are multiple other changes to these guidelines in which Kelsey is going to explain in further details.
Wonderful, thanks, Kim. So as Kim touched on some of the changing guidance and restrictions and, when can staff come back to work and what does this look like? I just wanted to spend some time reviewing this table from the CDC, which does provide some more detail again about when our staff should be restricted, when they can come back, how long they should be out, and as well as how their vaccination status plays into this. So, as we look at this table, the first row really reflects the guidance for our staff who have tested positive. The second row are those who have exposure to COVID, maybe asymptomatic, and that is divided up into, are they up to date with their vaccinations or not? So this just provides a high level overview and framework for, the next few slides of our discussion, and we will dig into some of the specific details associated with each of these. But before we do that, I thought it might be helpful just to recap some of these different tiers. So, conventional, contingency, and crisis standards, what are they? How do I know which one I should be in? And so really, I think the easiest place to start would be with conventional. So the conventional standards of care are sort of your everyday standard operations in a non-surge setting. Right, so this sort of is all-encompassing. It includes our administrative and engineering controls, PPE, and really everything else that you have implemented in your setting or facility related to your infection prevention and control plans. So really what you can think about for this setting or this standard would be like pre-COVID operations, right? So if we can think back to the era prior to COVID, just standard basic care. In this tier, we are not anticipating any sort of altered care administration. We're not seeing resource constraints, and staff are really practicing within their scope and experience. Then as we move into the next 2 tiers, contingency and crisis, this is where things start changing a little bit. So, you know, at the contingency level, we're doing what we can to make sure that we are maintaining a standard of care, you know, that sort of that baseline. The care that we're providing may be altered very slightly. We might start to notice some of these resource constraints. But, you know, the nice thing here is that clinicians and our, you know, folks within the facility are still really practicing within that scope. And then as we escalate further into crisis standards, really everything we would be doing in that conventional framework just goes out the window, right? So in this setting, we would be seeing altered standards of care, fairly significant constraints on resources, and clinicians and other staff doing anything and everything they can, whether or not that's in their sort of standard or traditional scope. But when we get to crisis standards, what we're seeing is that the needs are really outstripping the resources and the things that we can do and what we can provide. So all of that to say, you know, depending on which of these levels that you find yourself in will really determine on how you are going to handle your staffing needs, right? So in a contingency standard, you might be able to work with your human resources or your occupational health folks to assist in modifying what those return to work criteria are, obviously in alignment with, you know, CDC and other state and federal guidance, or potentially in here to find an alternate plan to get staff, right? So is this temp agencies, other creative ways that we can, you know, boost staffing in the facility. And then, you know, again, when we get into crisis standards, this is really where we might need to alter the way that care is provided and sort of readjusting those expectations based on where we're at with our staffing. So the CDC does provide some guidance on, you know, moving between these things. I think part of the challenge, though, is that it's not really that specific. And so it leaves a lot of us sort of uncertain on how to utilize these standards. And because it's sort of like up to each of us to, you know, figure out when we feel like we need to escalate from that conventional standard up to contingency or contingency up to crisis, it just makes it tough, right? So it's nice on the one hand that we have that flexibility, but sometimes without clear guidance, it's hard to know really when, you know, everything has sort of aligned or is the perfect storm. And really, we should be more seriously considering moving from a conventional to either a contingency or contingency up to a crisis standard. I think that said, you know, what I would ask you to think about or consider in this space as you're making some of these decisions, you know, transitioning to a different standard of care doesn't necessarily need to be facility wide, right? It might just be on a certain unit, but not in others. So don't feel like this has to be an all or nothing approach. The other piece is that the duration can be short, right? So if you have a handful of staff that resign or leave, you might escalate up to a different standard of care until you're able to get that resolved, whether it be temp staff, agency staff, hiring new folks, and then you can sort of go, you know, back down the chain, if you will. Whatever way you choose and however you approach this, absolutely, our recommendation would be to very clearly document this, why you've decided to do it, what factors led you there, just so that in the event that this comes up later down the road, you feel like you have this process very clearly defined and why you did what you did, so that, you know, if there's any question, that document has already, you know, been written and, you know, everybody sort of contributed and weighed in on that. So now that we kind of spoke about these different tiers, I want to go back and revisit this table and really dig into this first row in some more detail. So as a reminder, this row is for our staff who have tested positive and regardless of vaccination status. So you see there on the screen, it says, you know, up to date or not up to date, but they follow the same return to work patterns. And then depending on the standard of care you see as you move over to the conventional, contingency, and crisis columns, this is really where the guidance is, right? That will tell you how and when those staff can come back to work after receiving that positive COVID test. One of the things I want to point out here is that, you know, under the conventional section specifically, if we look at that, all it says is conventional. but it doesn't say anything about the severity of illness. And I think that's really important for us as we're considering how and when we can bring staff to work. So if we take just that one singular box, that top row, and look at conventional specifically, what does this look like in relation to severity of illness? And so this is a table that our team put together, really just breaking down that one singular box into 3 different levels. So from our asymptomatic staff on the left, all the way up to staff with a severe or critical illness on the right. So for asymptomatic staff, you'll see these individuals can come back either at 10 days after symptom onset, or they can come back earlier after 7 days if they get a test within 48 hours of returning to work. As we move up to our mild to moderate illness, these individuals in the mild category would have, signs and symptoms of COVID, fever, sore throat, cough, headache. And our moderate illness group would, be those with evidence of a lower respiratory disease and clinical assessment via imaging. So, fairly, again, mild to moderate. And this category, you'll see that they have the same 2 criteria as our asymptomatic staff, but they also add 2 additional ones, which are listed down at the bottom. So they also have to be 24 hours without fever, without the help of meds, and their symptoms need to be improving. As we move all the way over to the right, our category of severe to critical illness, these individuals might have, respiratory frequency over 30 breaths per minute, or O2 sats less than 94% on room air. And our critical illness folks are, respiratory failure, septic shock, multiple organ system failure, dysfunction. So really, really substantial and severe illness here. This is where you'll start to see that return to work guidance change a little bit. These individuals in that farthest right and most severe category can return to work somewhere between the 10, maybe up to 20-day mark after symptom onset. And then again, we're seeing these, the 24-hour have passed, right? Since they have a fever, no fever, without the help of meds. The one sort of caveat I'll add here, and we'll circle back to this in just a minute, is that in this group, we might also consider a test-based strategy. But before we do that, I want to sort of shift from talking about this conventional standards to what this looks like for our contingency and our crisis standards. So as we move from sort of that baseline up to our contingency standards, you can see that a lot of these criteria have either been shortened or eliminated altogether, right? So our goal in contingency is get our staff back to work as quickly as we possibly can. So as we start for our asymptomatic staff, you'll see we've shortened that return to work from 10 days to 5, and we've removed that testing piece. And then for those with a critical illness, right, all of the criteria from this category have been removed. What the CDC guidelines tell us is that we are allowing those who are well enough and willing to return to work to come back. Those who fall in a severe to critical illness category certainly are not well enough to work. These people are likely hospitalized, so that bucket really doesn't apply to them. Lastly, you'll see down across sort of the bottom of the table are our crisis standards. As I mentioned previously, everything we would love to be doing and would be otherwise doing if it weren't for whatever crisis we're in. Obviously, right now, this is COVID. All of that stuff just goes out the window. So at this point, you can basically do whatever you need to do in order to get staff into the facility and keep your facility running. So even if staff don't meet these criteria and you're in this sort of staffing crisis, it is appropriate and allowable under this crisis standards to have your staff return to work. Obviously not an ideal scenario, but it is, sort of part of the times. And so if this is something that you feel strongly that applies to you, or you're in this situation, that is something that is allowable. Again, I would just highly encourage you to document that as thoroughly as you can. All right, so now I want to go back to the test-based strategy I mentioned on the last slide related to staff who have either a severe or critical illness. So this is sort of some of the additional information about this test-based strategy. The one thing I do want to call attention to on this slide that's actually not written on here is that this test-based strategy can also be used for our healthcare personnel who are not moderately to severely immunocompromised if they have a severe or critical illness. So that's all, that column all the way in the right. This test-based strategy can apply to them as well as for our moderately to severely immunocompromised folks. And so this recommendation, again, is for our staff who are moderately or severely immunocompromised. And really, this is sort of why that's important. We know that it's a possibility they might have detectable virus in their system in either one of two scenarios. They are 20 days past symptom onset or 20 days after their first positive test if they have been asymptomatic. So they don't have the symptoms for you to count 20 days from, so you can count 20 days from that first positive test. And so given that, we need to adjust how we are testing and readmitting them, if you will, to work using a unique set of criteria. And so this is that set of criteria I was talking about. For our asymptomatic staff on the left, they are allowed to return to work if they have a negative test from at least 2 tests, at least 24 hours apart, using either an antigen or a PCR test. And the same thing for our symptomatic folks, but they also then, if they have symptoms, they need to be 24 hours without a fever, without the use of meds, and they also need to have improvement in symptoms. So, a lot of information to unpack here. I'm hopeful that some of the tables and images that we've put together will be helpful. Reading through the CDC guidance, your eyes kind of goes crossed. So we tried to help compile this and condense it in a way that you can take it, print it, hang it on your bulletin board, pass it out to staff, hang it on the unit, whatever you need to do, really to just make it very clear to those who are involved in this what this looks like and what your expectations are. But certainly, this is ever changing. So, again, why we felt that this was an important topic to kind of cover. So that's sort of the scoop on testing, return to work, and dividing between, the different standards of care as well as for those who are immunocompromised. So I'm going to pause there. I'm going to kick it back, Kim, to you to talk a little bit more through the staffing piece on our contingency and our crisis standards specifically.
Yeah, thank you, Kelsey. I appreciate that. Yeah, so, we're looking to maximize our interventions to keep everybody safe. So that's whether we're at a conventional, contingency, or crisis standard. And, we spoke a little bit about what these strategies are, but let's talk about some approaches you might take to mitigate them, to make sure that you're not escalating into a crisis, because that's definitely where you don't want to be. So first thing you may want to do is, close off your home to new admissions until staffing levels improve. And once you've identified your daily staffing needs, to provide your safe environment and your resident care, then you can adjust your staffing schedules. And if possible, hire and rotate these individuals. Adjusting schedules, they can be done by maybe you can create 4, 8, 10, 12-hour shifts. You could vary your shifts depending on responsibilities. Maybe your shorter shifts could be set aside for duties such as dispensing medications, while longer shifts could be used for cleaning and disinfecting the facility. Work with your staffing agencies to bring in temporary staff. It's another option. I had to say it, but most likely has been exhausted. Think about hiring additional staff by maybe you have some retired staff that might come back for a short period of time, students or maybe volunteers. You could also consider condensing residents into one area or areas to best utilize your staff. And you actually might need to cross-train your staff. So also during this time, during contingency, strategies, you should start developing regional plans to identify those care facilities that have adequate staffing for care for patients for COVID. Communicate with your local healthcare coalitions, federal, state, and local public health partners, your ombudsman. They're all significant in assisting with healthcare relief facilities with adequate staffing. And then, as described by so well by Kelsey, allow your asymptomatic healthcare personnel who have had a higher risk exposure to COVID but are not known to be infected to shorten their duration of work restriction. Okay, so you've done everything you can, but due to increased staffing shortages, you need to move to crisis standards. So here you'd implement now those regional plans to transfer residents with COVID to areas that have, healthcare facilities that have adequate staffing. Here you're going to allow your asymptomatic healthcare personnel who are not fully vaccinated and have high risk exposure to COVID, but are not known to be infected, to continue to work on site through their 14-day post-exposure period. And if shortages continue, despite other mitigation strategies, this is your last resort, is to consider allowing staff with suspected or confirmed infection who are well enough and willing to work, but have not met all return to work criteria, they can come back to work. Now, if this strategy is used, it's imperative to adhere to all infection control guidelines and that all people are wearing source control and wearing it properly. Well, the goal is to stay in conventional standards. But if you do need to move into contingency or crisis standards, we recommend doing the following. Okay, you're going to want to contact your local and state health department and your state survey agency. You want to let them know why you're taking these actions, what your staffing issues are, and all the actions you are going to take and have taken to find staff and to meet the residents' needs. And this documentation is so important. Like, you have other things to do besides document, right? But this is important. Document the why, when, how, and where it is making these transitions to contingency or crisis standards, as well as what aspects of the CDC standards you're going to be adopting. Document your efforts to find staff. And again, just continue to communicate with your state and local authorities. So, and then lastly, of course, notify staff that you have made a transition and what it means to them. So, for example, they need to know what work restrictions, they're going to be following, or you want them to follow while you're in like contingency standards or in crisis. So many of you have used the following resources to gain staff with or without luck. Examples to gain staff could be, you could put in a request to the local governor's office for National Guard support, call your ombudsman to ask for help, reach out to your local healthcare coalitions, your temporary staffing agencies, or reach out to other healthcare providers such as your hospitals and maybe your sister facilities or other long care term providers. We have also included state-specific links on our resource slide of this presentation. It has staffing plans and staffing resources, which could be helpful if you find yourself having to, move in or out of conventional standards. So that ends our presentation. It is, oh, holy cow, it's 1:29. That ends our presentation. I was hoping that we would have a few minutes to answer questions, but I see that we're at 1:30. So I do want to just show you here on our slide presentation. These are the resources, 3 of them that I spoke about, and then also some other strategies to mitigate healthcare shortages. And I also then did put on the free at-home COVID-19 testing that is available for everyone now in the United States. And also, if you know what, you want to continue this conversation and you do want to ask some questions or have other topics, come and join us in Superior Health Connect. This is a shared learning environment. You learn from us, you learn from your peers, you get to ask questions, and it's all with one goal in mind, and that is to improve healthcare quality. So that actually is the end of our presentation. Again, I hope that this was useful to you. We do have the slides in chat. And if you could please, we would greatly appreciate if you could give us some feedback on the survey that is also in the chat. That is also in the chat box. Kelsey, just before we leave, I know it's 1:31. Is there anything you'd like to add?
I don't think so. No, this is great. We crammed a lot into a half an hour. Thank you all for hanging with us. And as Kim mentioned, if you do have any other questions, feel free to drop them in the chat. We're always collecting those. And now that we are meeting weekly, we can certainly circle back to some of these next week. And with that, would love to see you all back next week, Wednesday, same time, same place, noon Central, 1 p.m. Eastern, for another 30-minute conversation. And with that, wishing you all a great rest of your week, and we will see you next week.